10. All right, study guide for EMC 320 final exam. We are recording today. So when we're talking, let's go down and go through number one. So when we're talking about events that happen in a motor vehicle accident, basically what we're looking at are multiple impacts. Stick something over there so that people can get in if you don't mind. Yeah. Boy, that was nice. Anyway, basically we have the car that impacts the tree, and then we have the patient that impacts the interior of the car or the seat belt, and then lastly we have the organs that impact the skeletal system. And you got to understand that from those three impacts is where we're going to get the majority of our trauma that's going to occur. And again, so keep in mind that those three impacts that occur. We didn't have a lot of time to talk about blast injuries, but in particular, here's the things that I want you to remember about blast injuries, okay? Again, much like automobile trauma, there is also multiple phases to a blast injury. You have the primary blast or primary injuries that come about as a result of the blast wave itself, okay? You have secondary injuries that come about because of shrapnel as well as being blown back against something. And then you have tertiary injuries of anything that may collapse in on top of you. So again, that's why you can see both blunt force trauma and penetrating trauma with blast injuries. Somebody tell me what you know about compartment syndrome. First of all, what causes it? As a result of what? You're right. Just fill that out a little more. Trauma to the area. What else? Okay, you can't talk. Be quiet. Save your voice. Okay, so a heavy weight, something that can fall on it, okay? And so what are the issues that we are really, really concerned about as far as compression syndrome? What's the pathophysiology that occurs from it? Say it again. The toxins, and in particular, what toxin are we looking at? Potassium, okay? Potassium, fatal to the heart, all right? We also get a lot of acid that gets produced, all right? And so as we're looking at that, that's the thing that we're going to be looking for with these patients. And again, sometimes it's hard to tell the difference between a compartment syndrome and a crush injury, but the end result is pretty much the same, okay? With crush injuries, you're going to have more direct trauma to the tissue. With compartment syndrome, you're going to have indirect trauma to the tissue because of the edema that is occurring in there. Yes, ma'am. Okay.
So, traumatic aphasia, even though something is on your chest, is not the same as
Traumatic asphyxia, and again, as we're going through this, if you have questions, make sure you ask them. Traumatic asphyxia comes about as a result of a sudden compression on a patient's chest. The best example is you got a dude just working under a car falls off the jack impacts his chest, okay? So we have multiple types of injury patterns that we can see with this. We can have hemopneumo to the chest. We can have cardiac tamponade to the chest. But again, specifically what you're talking about as far as traumatic asphyxia is that it causes a sudden backup of blood, and you will see a number of signs and symptoms. So you may see purple splotching on the patient's chest, bloodshot eyes on here. The other thing that you may see, and this happened to me with the same scenario that I gave you, is that when you start the IV, you may actually get blood that backs up into your IV bag because of the sudden pressure that's on the chest. Bella.
So what is the difference between crush injuries and
Crush injury, the the trauma to the patient comes about more so as a result of the direct trauma to the tissue. So, for example, the compression causes that trauma to take place. Many times with crush injury, you'll see compartment syndrome and vice versa because you've got the mechanism of injury. Person gets a hand or an arm, a leg hung up in some type of an industrial machine, and it clamps down on that. With compartment syndrome, a good example of compartment syndrome that would be more so from the edema that's building up would be, let's say you've got somebody that's out digging a trench and they don't have it shored up safely or correctly, and it falls in on them and they're trapped from their waist down. There's not a lot of pressure there that would cause direct trauma to the tissue, but there is enough there that now begins to block off blood flow. And as a result of that, now your tissue begins to die of hypoxia rather than direct trauma. Does that help? Yeah. Okay. Anybody else? Okay. Low, medium, and high velocity penetrating mechanisms to various body tissues. Here's the things that you need to remember about that. Solid organs will sustain much more damage from gunshot wounds than will hollow organs because solid organs can't displace the pressure as easily as hollow organs. Now, that doesn't mean if you get shot in the chest and it goes through the lung that it's better for you than if you get shot in the liver, okay? Both of them can be pretty fatal, all right? But understand, as far as the amount of damage that's done, you're going to see a lot more damage here with everything else being equal going through a solid organ than you will going through a hollow organ. Why? Because of the principle of cavitation. You have permanent cavitation and you have temporary cavitation. The permanent cavitation is actually caused by the projectile itself. And the thing I want you to remember about cavitation is think about the wake that follows behind a boat. All right, so as you see a boat going through the water, you can see that trail that widens out from behind it. That's the exact same process that happens in the body with cavitation. Direct or permanent cavitation, again, causes damage. It's just the metal projectile that's going through the body and it wipes out tissue. That tissue will scar. Depending upon the organ that it impacts, will determine whether that organ will regenerate or not. Out ahead of the projectile, you've got a small column of compressed air. We know that when things move through the air at supersonic speeds, the air gets compressed in them and around them. That stretches and compresses the organ that it's going through, causing temporary cavitation. So it just basically compresses it, and then over time, it will begin to re-expand. You're still going to get some damage from temporary cavitation, but not to the extent of permanent cavitation. Taki. Okay, say that a little bit louder for me. I'm sorry. So you're asking if it would not be the hollow organ that would be worse than the solid? So no, it's actually the opposite way around, because remember, energy gets transferred. This goes back to that very first lecture we talked about energy transfer. Energy doesn't transfer as much going through a hollow organ. Why? Because it's either full of air or fluid, depending upon, and basically what we're looking at here as far as hollow organs would be like the lungs, the stomach, the intestinal system, or the bladder. The intestinal system, I guess you could make an argument that it's full of semi-solid, but most of the time we would consider that to be more of a liquid than anything else. And again, because of the energy transfer, we have a reduction in the amount of damage that will be done to hollow organs as compared to solid organs. If we take the liver, and again, one of the things we're hoping to do for you guys over the summer is to take you to University of Louisville's cadaver lab. You will see the difference in what a lung feels like as compared to other organs. Because you have so much tissue there, there's more damage to sustain. And so that's why solid organ projectile injuries are much more severe as far as the degree of damage than hollow organs. Now, again, don't misunderstand. You get shot in the chest, you got problems if it just simply goes through the lung. You get shot in the abdominal cavity, you got problems, all right? And so none of those are good, but as far as the amount of damage that occurs, it's more so in a solid organ. Does that help? Okay, anybody else? These are good questions. All right. Discusses the disruption of homeostasis that occurs due to hemorrhage and the body's compensatory mechanisms attempting to maintain homeostasis. So basically, this question is just wanting you to know how does shock happen and what's the phases that it goes through. Shock, bottom line, inadequate tissue perfusion. Sometimes we say that because that's what we've been taught, but we don't really think about what happens. So here's the thing I want you to really, really dig into, is understand what that means. It means we have inadequate delivery of oxygen. No, bless you. Know what that means. We have inadequate tissue, inadequate delivery of glucose. Know what that means for our patient. And then we have inadequate removal of waste products, in particular carbon dioxide. Again, for the patient, make sure that you know what each one of those three abnormalities mean. As we go through, inadequate oxygen, patient now becomes hypoxic, okay? The similar thing happens in the fact that we're not able to remove out carbon dioxide, which means our patient becomes more acidic. This is one of the reasons why we want to kind of shy away from giving normal saline to our patients, Rihanna. Why? Because if our patient is already acidic and we're giving basically salt water or pasta water, if you think about it, salt and water, we're going to make them even more acidic, all right? And so we want to try to offset that. Now, there's no way that we can offset that with the exception of doing what? What's the only thing we can really do to offset acidosis and trauma? Ventilation, okay? So whole blood is not widespread yet. It's coming, okay? Now, whole blood will help to swing that back over here, okay? One of the things that we'll be doing in the summer, again, is I'm working on figuring out how do you simulate administration of whole blood, and I'm in several discussion groups, because you guys will learn in 362 how to administer whole blood, because it's coming. So that whole blood will be a thing that you can do. But for right now, ventilation is the thing that we're going to do to swing that back. That's why, again, on your trauma patients, make sure that they're on both their SpO2 and Untitled, so you can watch that CO2 go up or down and manage it by your ventilation, all right? You should always check a blood sugar on your trauma patients. Okay, because we want to find out, is that blood sugar level going down? Now, it will not happen often, but you may occasionally have to administer some glucose to your patient, especially if you've got a diabetic who has now been injured in some type of trauma, which leads us to those phases of shock. Again, the way the adult body compensates for shock is through increase in heart rate and vasoconstriction, all right? Now, let me take just a step back a little bit. One of the challenges in particular that infants have, but this begins to change as they get older, is that infants do not have the ability to vasoconstrict. And remember, infants are classified as newborn up through 12 months. So the way that they compensate is solely by increasing the heart rate. This is one of the reasons why they don't stay in the decompensated phase for very long. They'll compensate really well, but when they decompensate, decompensate and they fall off the edge. Very similar situation as to what you will see with geriatric patients. When we now move over into the decompensated phase, now we begin to see the compensatory mechanism, primarily the vasoconstriction of the body, beginning to fail. Why? Because the heart rate's still up. So we'll have a tachycardia, but now our patient is beginning to vasodilate. Again, why? Because they're not getting enough oxygen. They're not getting enough glucose to help to offset that. The other thing that comes about here is that if CO2 begins to build up, what happens to the vasculature anyway? You're exactly right. So it begins to dilate. Again, another reason why your trauma patients should have end tidal on them all the time, end of story, okay? So, decompensated, heart rate goes up, blood pressure begins to fall, and now we begin to see, in particular, shunning from the extremities into the core. The final phase here is irreversible shock. Everything's failing. Heart rate falls because the heart is just, as we say in the South, it's just give out. It will not work anymore. Your vasodilation is widespread. It's everywhere. Again, because of CO2 that is beginning to build up and the patient's becoming more acidotic. Respiratory rate falls. Getting your patient out of this phase, difficult, not impossible, but very, very difficult. All right. Any questions on that? If you have a really good grasp on what I just shared with you as far as shock goes, you'll probably answer half the questions right. Cindy, why are you making that face? Did I confuse you?
No, I mean, it makes sense right now, but when it comes to the passage,
That's why I'm recording it, so you can play it when you go to sleep and I can be in your nightmares. Okay? All right, any questions on that shock process? All right, that's important. That's important. Let's see, define internal and external hemorrhage and discuss appropriate progressive measures for managing it to include tourniquets. There's only two things we do for bleeding. One, direct pressure. If it doesn't work, number two, we go directly to tourniquets, all right? The other thing, and we'll talk about this, and I should have included this with shock. I think I've got a question on here in just a little bit about this, is number one, you got to keep your patients warm because they will not clot, and acidosis accelerates in patients that are hypothermic. So we want to keep them warm. We never use the Trendelenburg position anymore, okay? If you see that on a question, I want you to think 1970 called and they want their curriculum back because that's just bad medicine. When we do that, what we're doing is that we're manipulating the spine. So if we've got a potential of a spinal injury, as well as if your patient's got a head injury, now we run the risk of increasing the intracranial pressure. Maybe not on purpose, but it's still increasing anyway. So we don't use Trendelenburg. Remember, Trendelenburg is raising the feet up about 12 inches or so. So you can kick that one out right away. Describe the effects of hemorrhage on categories of special patients, such as pregnant women, athletes, obese patients, children, and the elderly. Okay, pregnant females. Number one thing to remember with pregnant females is, especially in late-term pregnancy, is what? Say it again. So, yeah, we're going to focus because by treating the mom and not worrying about the baby, we're going to take care of the baby. Okay, Rihanna. No, they actually have lower pressure. So as the patient progresses through the pregnancy, the patient's blood pressure drops. Blood volume also increases, and a chemical that makes the platelets less sticky also increases. Why? Because as the blood gets slowed down going through the placenta and in through the umbilical cord, the last thing we want are blood clots that will develop either for mom or for baby. Now, the downside of that is if mom has some pretty severe trauma, she's going to bleed more profusely. But the other thing, somebody had a hand up over here. Who was it?
I was going to say, you leave her, if you put them on the back, you can lower this.
What's that called?
No, the bank.
Supine hypotensive syndrome. And that's the other direction I was going to go. Your patient, your late-term pregnancy patient, by late term I'm talking about the last 4 to 6 weeks, needs to be placed on her side when at all possible. Okay, so if your patient's not on a backboard, just have her roll over on her left side. It gets the fetus off of the vena cava. If you lay her flat, if you lay her supine, it's going to compress the inferior vena cava, reducing preload coming back to the heart, reducing cardiac output. And your patient may be fine, but she may show signs and symptoms of shock. Colin.
If you have extra hands and she's on the board, can you try to support some that way as a feeder?
So if she's on a board, the simpler thing to do is just simply tilt the board. Take a lot of stuff, pat it in behind the board, make sure that board is cinched down nice and tight because now the surface area is less, and literally she can slide with the board up towards the front or even towards the back, but more so towards the front if your partner has to stop the ambulance quickly. So on the board, we'll tip her over at about a 45-degree angle. She doesn't have to be over like this. Generally, if she's not on her board, she will go over at about 90 degrees, just laying on her side. In a cardiac arrest situation, whether from medical or from trauma, neither one of those are going to work. So what we've got to do is we've got to get one person reaches across from the left side and displaces or pulls the fetus towards them. It's not going to get the fetus completely off of the vena cava, but it will get it off enough that we can restore preload and have adequate cardiac output. Any questions on pregnant patients? Say it again. For them, basically everything else that we're doing for any other type of trauma patient. Keep them warm, watch their oxygenation, watch their end-tidal CO2. Depending upon the severity, will determine whether you're going to start one line or two. Okay? If you have a patient that basically has minor trauma, and by minor trauma I'm talking like an extremity fracture, one line is probably going to be enough. If you have any suspicion that we've got any trauma to the core of the pregnant patient, then get 2 large bore lines. Okay, and by large bore, I'm talking, if you can, a 16 or a 14. All right, 18 to me is not a large bore IV for trauma. Okay, it is larger, and we can utilize that for different types of situations. But again, you have to go with what you can get. But if you have an option, and most of the time women that are pregnant are relatively young, so if their veins have not collapsed as a result of shock, you'll usually be able to get a fairly large bore IV started. Okay, so it'll be the same thing that we would do for everybody else. Athletes, the big thing we're looking at here is that their heart rate will generally be slower, just simply because of the shape that they're in. All right, got to take that into consideration in the fact that that might work against them as they try to compensate. The good part about being an athlete is the contractile force of an athlete's heart will help to adjust for some of that slow heart rate. Obese patients, big thing that we're looking at when I'm talking about obese patients, I'm talking about morbidly obese patients. When we lie them flat, 2 things happen. Number one, if they've got a lot of chest tissue, that's going to press in on their chest. It's going to make it more difficult for the chest wall to expand. especially when we've got any kind of chest wall trauma. Number two, gravity is just going to take over, and the abdominal contents are going to have a tendency to shift upward, which is going to have a negative impact on the patient's diaphragm movement. And so that's going to reduce it as well. Again, there's not a lot that you're able to do in that situation. Potentially, if it's from abdominal, what you can do is potentially tip your patient over, much like we would with supine hypotensive syndrome patient, pregnancy patient, to help to reduce some of the pressure on the diaphragm. But we may have to increase the percentage of oxygen as well as the rate and the depth of our ventilation to offset that. Martina.
A runner or a person that runs that exercise, are they more acidic than most normal people are due to the fact that they train their body to run off of not aerobic but anaerobic? And so they'll like to have foods a little bit more in their body than it is not.
So no, actually the opposite is true. They've trained their body to be really, really efficient with aerobic metabolism. So basically what they see when they're training, the amount of acidosis that's in their body is actually diminished than if you've got someone who is not an athlete, but still a healthy person who has a similar type of situation. Basically with their heart rate is going to be at a lower rate, but the contractile force, again, coming into play there, the Starling effect, is going to be much more efficient to help to adjust for that. And they're going to be able to have better vasoconstriction. Okay, for good. Anybody else on that? Elderly patients, and children, we've already talked about the potential of them going quickly from compensated to decompensated. Children, because their compensatory mechanisms are not yet developed. The elderly for two reasons. Number one, their compensatory mechanisms are worn out. Number two would be some of the medications that they take. Beta blockers would be a big problem because why? It slows down the heart rate. It reduces the contractile force. Calcium channel blockers would do what for our traumatic geriatric patient? So it doesn't have anything really to do with the heart rate, but it does reduce the contractile force. And the other medication that you need to be familiar with, and we just briefly touched on this, are called ACE inhibitors, ACE, angiotensin converting enzyme. Just remember ACE inhibitor, okay? ACE inhibitor is a medication that keeps angiotensin from converting into angiotensin 2, which ultimately results in vasoconstriction. Okay, so the big thing I want you to remember for the exam is ACE inhibitors will not let the patient vasoconstrict. Beta blockers, similar situation. Reduces the blood pressure by vasodilation, reduces the heart rate, and not so much by vasodilation, but beta blockers reduces the heart rate and the contractile force. Calcium channel blockers reduce the contractile force of the patient. We've talked about number 8. Number 9, integrate the principles of ventilation and gas exchange with the pathophysiology of trauma to identify patients with inadequate perfusion. This comes across the board in all trauma, but in particular with chest trauma. When we're looking at issues of chest trauma, particularly in the area of perfusion and diffusion, make sure you know the difference between those two words. They're both critical to our patient, but they're two entirely different functions. Perfusion, circulation of blood through the body. Diffusion is the movement of gas, both at the alveolar level and over here at the cellular level. If we have a patient that has chest wall trauma, whether it's blunt force or penetrating trauma, the things that we're concerned about are the destruction or the impairment of the alveoli. Alveoli get destroyed, No oxygen is able to go into them, or no air is able to go into them. No CO2 is able to diffuse from the blood into them. Therefore, our patient becomes hypoxic and acidotic, okay? When we have fluid that now begins to fill up, particularly in patients that have hemothoraces, okay? Not a pneumothorax, but a hemothorax. Now, remember, gas and liquid cannot occupy the same place at the same time. Bless you. Therefore, we're not going to get gas exchange in the alveoli because of filling up the alveoli. So we're going to have a negative impact on perfusion. Diffusion. Perfusion will also be impacted because if blood is anywhere other than the vasculature, it no longer carries oxygen or carbon dioxide back. So if we get blood that moves into the alveoli, that blood is completely useless now. Okay, that's the thing to remember on that one. Minute volume. What is minute volume? Yeah. So it's actually your respiratory rate times your tidal volume over 1 minute. Okay. So here's the thing to remember about minute volume. In the normal patient, if the respiratory rate goes down, what happens to the tidal volume? It goes up. And the vice versa is true. Okay? So, for example, Bella, we get a patient that has fractured ribs. What's going to happen to their tidal volume? What's going to happen to their respiratory rate? It's going to go up. So you're on that whole seesaw type of process with rib fractures, with chest trauma. Tidal volume is going to fall because your patient, it hurts to breathe. Therefore, the body recognizes that through both baroreceptors and chemoreceptors found in the vasculature as well as in the brain, and now it will raise up your tidal volume. With your chest wall injuries, what is one thing that you can do from a pharmacological perspective to help improve tidal volume? Be generous with pain management. Now, keep in mind, you're standing right there on the edge of a two-edged coin, okay? We want to be generous with our pain management medicine. Because what we want to do is we want to improve the respiratory status and increase the tidal volume. One of the downsides of most of the pain medicines that we give is that we can cause respiratory depression. So start low and gradually ramp up as far as if your patient needs more, okay? And then again, don't be afraid that if your patient begins to decompensate in their respiratory drive, shoot them up with a little bit of Narcan to improve their respiratory status. Number 11, basically the things that I want you to know is under that, the various type of brain injuries that can occur after trauma would be subdural and epidural hematomas. A subdural hematoma, remember, is underneath the dura. Epidural is above the dura. The dura is that tough covering of the brain that helps to protect it. With epidural, basically, it's going to be more venous, which means your onset of symptoms is going to be slower. Literally, it could take hours or a couple of days for a patient to progress from just having a really bad headache to becoming unconscious because of the pressure. With the subdural, we're looking at primarily things that are going to cause a problem from an arterial perspective. Arterial bleeding, high pressure, venous bleeding, low pressure. With arterial bleeding of the brain, those symptoms are going to occur quickly. Number 12, intracranial pressure, autoregulation, and detrimental effects of increasing pressure on the brain in both the adult and the ped patient. As the intracranial pressure goes up from trauma, the arterial system gets, technical medical term here, squished, okay? So it's like stepping on a water hose, which means the body recognizes that the blood is now going through a smaller diameter vessel, which means the body recognizes we got to raise the pressure up because the body will try to perfuse the brain at all cost. And so that pressure will now begin to go up. And it is literally, the dog chasing its tail. As the pressure goes up, more death of brain tissue takes place. Eventually, the pressure gets to a point of where now the tissue begins to extrude through the foramen magnum. When that occurs, don't be surprised to see your blood pressure go from just a huge, like 260 over 120, down to 140 over 90, really, really quickly. Don't get all excited and think, I've done a good job. You may not have done anything at all, but for all means and purposes, this is the end for your patient. Now, they may continue to survive, but they will live out the rest of their days in a persistent vegetative state. They are no longer the person that they were before, okay? In what we're looking at here, and I've got a question in here about this as well, remember Cushing's triad, which is made up of what three things? High blood pressure, low heart rate, and irregular respirations, okay? The other thing to remember with the very good, you're really good at sign language, is increasing increasing pulse pressure. You get your pulse pressure by taking the difference between the systolic and diastolic blood pressure, and you trend that out. As that number gets larger, now that indicates that our pressure is increasing. The other end of that is important as well. If you've got a patient that has trauma, not to the head, but somewhere else, you still should be calculating a pulse pressure on them and looking for a narrowing pulse pressure. Narrowing pulse pressure means the number is getting smaller. That tells us that our patient is moving from whatever phase of shock that they're in into the next phase. Martina. No. Well, the pulse pressure will drop dramatically with that pressure as well. So yes, you're exactly right. So as it extends, okay, and as the brain gets pushed through the foramen magnum, now we've got brain matter that's down in here that's also beginning to potentially displace some of the cervical spine. So we have some of the mass of the brain that's been removed from the skull, so we have a drop in the pressure. So yeah, that pulse pressure will drop as well. Good point. Hadn't thought about that, but you're exactly right. Anybody else on that? Okay. Cushing triad. So what do we do for our patients with head injuries? How do we treat them? Tell me more about the oxygen. Okay. Now, oxygen administration isn't really going to have a huge amount to do with the presence or absence of CO2. Luna? Say it again. As we blow off CO2, it constricts the vessels even more, which means what? Now we have decreased perfusion to the brain, which kills off cells. The thing that we need to be looking for is a phrase called controlled hyperventilation, okay? And that just simply means that we will ventilate our patient up on the upper end of the normal range, which is between 12 to 20. That ventilatory rate and tidal volume must be guided by what? Make me proud? End tidal CO2. End tidal CO2. Yes, ma'am.
So what do you want their CO2 to be at? Because that was a question on the exam.
We would like for their CO2 to be on the acidic side of normal. So normal CO2 is what? So we would basically want it to be somewhere between 40 to 45. So we want that increase in CO2 to be in there. Did I say something wrong? Okay. Say it again?
I said, well, I got that one wrong.
Okay. Well, that's all right.
40 to 45.
No, we want it between 40 and 45. Obviously, we don't want them to swing over into acidosis. So if your CO2 is going up and you got CO2 of, let's say, 50, 55, what are you going to do? And deeper. Okay, so we're going to increase tidal volume. We're going to increase the rate, and we're going to watch our end tidal really quickly because the changes that we see within our end tidal are almost instantaneous. Okay. And so this is why I'm a big fan of end tidal because it does so much more than just letting us know that our tube is in the right place. All right? Yes, ma'am.
So the blood that's going into the head and the vessels there are different pressures that confuse pressure for the brain is different because the way I'm confused about it is somehow like it's saying that the more pressure we have here is giving more fluid to the brain or
It's trying to.
okay. And so then if it's giving more fluid to the brain, shouldn't we constrict it so that it won't give that much blood?
But now, so it's a two-edged sword. If we constrict it, what else are we not giving it? And what's not being carried away? Yep. So basically, what we want to do is we want to try to keep the brain perfused. And that's why we look at our end tidal more so than what our pressure is as far as what our target. We're still going to use our target in the fact that if the pressure continues to go up and we correlate that with our end tidal, then that's going to regulate our rate and tidal volume. Anybody else? Okay. Let's see. Let's describe common pulmonary and chest wall injuries seen in the pre-hospital environment. No signs and symptoms and treatment of tension pneumothorax. Primarily, the treatment for a tension pneumo at this point is going to be what? Needle decompression. Okay. Again, we'll talk about finger thoracotomy a little bit later on in the summer, and then that will be added to your repertoire. What is our treatment for hemothorax? Positive pressure and drive faster, and if necessary, fluid replacement to maintain the pressure. Okay. Cardiac tamponade. What's our pressure? What's our treatment? Why fluid? Yeah, good. So we give our patient a fluid bolus, and the formula for an adult is okay, and for a pediatric, somebody other than Colin. Good. 10. Say it again.
Hypovolemic shock in pediatrics.
Is also 10. For peds, it's 10. Okay. Have you seen something different?
Yeah, in the hospital, it's
Okay. Keep in mind, again, you want to follow your protocols, all right? But the other thing to also keep in mind is that this is what you'll see on your registry exam from both PALS and PHTLS. So again, you guys are going to have to live in two worlds for a short period of time. And so it's my job to kind of tell you where those are, okay? All right, good point. Good point. Again, with cardiac tamponade, we're going to give a fluid bolus because of Starling's law. We give that fluid bolus, God bless fluid, it stretches the heart out, increases contractile force, and it can potentially, again, technical medical term, squish out some blood from that's surrounding the heart. Let's see. Mechanism of injuries, signs and symptoms and complications with abdominal injuries to a solid, hollow organ, retroperitoneal organ, and pelvic cavity organs. Yes, ma'am.
What about if you have a hemolymph?
Okay.
Do you guys start to
So let me ask you a question. How would you know if you have a hemopneumo? So Devin's telling you here, for one thing. I mean, this will be one finding. Okay. How would you know if it's a hemopneumo though? I'm not making it hard. I mean, you bring up a good question. So if somebody help her out, okay, let's phone a friend. Okay. Different sounds in different areas of the chest. Typically, the front part of the chest, the anterior chest, is going to sound more hollow. Posterior part of your chest will sound more dull because blood follows gravity. All right. So if you've identified the potential that you've got a hemopneumo, are you going to decompress the chest? Devin's saying no. Why no?
Because even if, I don't know, I'm trying to think. I have my answer.
Okay, think about it for a minute. Anybody else? Cindy.
Isn't it like decompress it, which would potentially because there's pressure, but there's no pressure to decompress?
Well, now, with hemopneumo, you've got both blood and air.
But it's like you fix one problem, but you can't fix the other one. But can you really, I don't know.
Taki. Okay. Anybody got anything there? Martina.
I say equal it, right, because the more we let it sit, the more it's going to shift. And so you're going to need the heartbeat out. The question for me is, how would you distinguish what to do first? And that would be the issue for me. Even if you do this, you put the shift, there's more pressure, you're losing one lung.
Mhm.
And then you're going to be to the point you only use this one. Now you're drowning in secretion. So you have two different treatments that you can do for the blood and you can do for the artery. So at the end of the day, which one would you even use first?
I love the thought process that's going on here. And I'll come to that here in just a second. Colin.
A little bit of fall off of what she said, right? But if you decompress, you're at least releasing some sort of pressure. And hopefully you get to the hospital or closest trauma center where maybe they can drain some of the blood.
Okay.
At the end of the day, if you decompress and it starts bleeding more, it probably will keep off that catheter. It's gonna
Potentially.
end up doing what it's gonna do regardless.
Okay. Rihanna.
Would they bleed a lot? How would they bleed that much?
Okay.
I mean,
So
so
that
I,
depends as well, because if the pressure's high enough that there's no more volume for it to build,
So here's what I would tell you. Here's the Bill answer. Number one, I wasn't even going to say it depends. I was going to go with number one. In a hemopneumo, you've got both problems. You've got blood, and in particular, the two things we're worried about with a pneumo. See what you've done? It's a good thing.
I was thinking it, so.
It's a good thing.
No one knows the exact answer, so.
Well, we're going to come up with an answer because I've heard several good parts of the answer already. So number one, with a hemothorax, we're losing blood. Okay, so it's a perfusion problem, and that blood is filling up the alveoli, which makes it a diffusion problem. All right. Now, Devin, you're exactly right. There's nothing that we
They need
can
a chest
do.
tube, ultimately.
They need a chest tube. Okay. Well, not yet. Not yet. It's coming. Trust me. Because remember, you're sticking your finger into this person's chest. Why can't we just put a tube in as well? Anyway, so there's not much that we can do as far as the hemothorax. We can maintain the pressure and we can take care of the patient's ventilatory status to the best we can. With a pneumothorax, we also still have a perfusion problem and a diffusion problem. Perfusion problem is because now we begin to get that shift, okay? And we identify the shift primarily by what? No. Remember, what did I say about tracheal deviation? It's very late and rare. JVD would be one thing that we would see fairly early. What else would we see even earlier than that? Say it again.
Signs of
Signs of shock. So if our patient is beginning to drop, to have a perfusion problem, now we've got signs of shock. Guys, I will tell you, in most situations, you're going to say, I'm not really sure, is it a hemo? Is it a pneumo? Or is it both? In that situation, if you hear diminished breath sounds, typically what you're going to do is you're going to hear more diminished breath sounds with a pneumo than you will with a hemo. Why? Because the breath sounds that you will hear with a hemo will usually be what? Say again? Now, wrong guy. Crackles. Crackles. And you'll hear crackles in one place, okay? Now, if you don't know whether it's a hemo or pneumo, but you're pretty sure it's one or both of them, sticking a 14-gauge needle into the patient's chest is not going to make them bleed anymore. And it might save their life, okay? So go ahead and do that. The other thing is, again, we'll practice this. Don't be afraid to do a needle or a finger thoracostomy on our patient, especially if they've already got the opening already made for you or wherever it is. So again, because remember, I told you that from a real life perspective, when you decompress a chest, Landon, what did I tell you I wanted you to do in real life? Again, depending upon your protocols, but what should you do? Both sides. You're going to decompress here, you're going to decompress here. Why? Because one needle is not going to remove enough air, okay? So you don't have to worry about causing more bleeding because what you're putting in, not that big. So basically what we're trying to do is slow down the dying process to get them to where we can get a chest tube in to pull out the air and the fluid. Colin, really good question, by the way. Well, it all depends because remember now, when you've got your patient, if you've got chest wall injury, most of the time they're going to be supine. And most of the time, where's that blood going to be? Back here in the back. We're going to either decompress mid-axillary or mid-clavicular. So our needle is going to be up fairly high, even here in mid-axillary, and most of the blood is going to be back here to the posterior part of the chest. So you could potentially have a patient that has a hemo and you don't have any blood come out of your decompression catheter at all. If you got blood that's coming out, your patient's probably ready to go into cardiac arrest because most of the blood is in their chest. Martina.
Oh, because that's my question. So they are saying to you, before you
Now, positive pressure, again, is a two-edged sword. Yes, we want to maintain ventilation, but also remember that even if whether we've got an opening from the chest in, a sucking chest wound, or if it's a closed chest wound, every time we're pushing air in, we're getting air that's escaping. So you want to watch your patient's perfusionary status by looking at their vital signs, and you want to watch their diffusionary status by assessing SpO2 and their end tidal. All right?
So we're decompressing.
Yeah.
Okay.
That's my long answer to your short question.
Awesome.
All right, good. Number 16 talks about injury to intra-abdominal vascular structures. Just to understand, particularly the solid organs of the liver, the spleen, they bleed a lot because they make blood, okay? That's a big thing to know about that. Identify the types and describe the pathophysiology of syndromes associated with spinal cord injury. Go back and review central spinal shock and anterior cord spinal shock, and also know the symptoms that come about as a result of swelling that is temporary with our patient in spinal injury. So swelling can cause temporary loss of function. As that swelling begins to reduce, now function is returned. This may be one of the things, depending upon, again, what your protocols call for, where in spinal cord injuries, you may be called upon to administer a steroid, again, to get that steroid started as early as you can to reduce the amount of swelling that's going on. Just know the difference between superficial, partial thickness, and full thickness burns. And in particular with burns, what I want you to know is to, number one, know that you can have fluid shifts, which lead to hypovolemic shock. And then number two, the area that is burned leads into hypothermia for our patient, which is not a good thing for them. Let's see. Common pitfalls encountered during disaster response. Basically, the biggest thing we're looking at here is confusion in communication, just simply because you have so much that's going on. And this is really, really relevant right now. And I got to admit, news media has gotten better at this, but they clamor and clamor and clamor for information following a disaster. And then they'll jump all over public safety agencies when the information that they're given is wrong. Well, they're not trying to hide anything. They're sharing the best information that they have at the time. Hyperthermic conditions, know the difference between heat exhaustion and heat stroke, including the fact that your heat stroke patient can indeed have moist skin. Right? It is wrong to think that your heat stroke patient will always have hot, dry skin. And the biggest thing that we want to do for our heat stroke patients, as well as our exhaustion patients, is to cool them down, get them into a cool environment. If they're having heat cramps, we want to administer some type of a saline solution, probably nothing by mouth because we don't want them to vomit, particularly if we're running the risk of that temperature continuing to go up, resulting in a loss of consciousness. For your heat exhaustion and your heat stroke patients, most definitely nothing by mouth. We're going to give them cool fluid. Colin. Yeah, the 5 types of weapons of mass destruction: chemical, biological, radiological, and nuclear. Yep. Similar situation of knowing the difference between hypothermia and frostbite. Ryan.
I had a question on the heat stroke and exhaustion. What's the best way to cool it down?
The best way, it's interesting, I'll try to remember to share this with you, but the best way to cool them down is to put them into a tank of ice water. Okay, now, I don't know about you, I never carried a tank on my ambulance. However, Hand Heavy came out with something that I thought, well, that's really pretty cool. What you do is, and again, you'll have to get creative as to where you will find it, is use a body bag. Fill the body bag up with ice water, or put your patient, probably easier to put your patient in the body bag first. Little hint, don't zip their head up, okay? Not going to look good in the paper and not going to get you a really good patient evaluation. Leave their head out, okay? And then just begin putting ice water, not just ice. You got to have water in it because the water really begins to reduce the body temperature quickly. Now, for our friends in Saudi Arabia, do you guys have heat-related emergencies, or are you acclimated to it?
But sometimes I get dizzy.
Do you? Okay.
So, yeah, I almost passed out.
Okay. In Saudi Arabia or here?
No, not here.
Okay. All right. Okay. I worry about you guys in the wintertime because, and we don't even really have real winter here. So what about people that are visiting Saudi? Do you see an increase? Americans, yeah. I want to go to Saudi Arabia, but you guys got to tell me when the cool time is. I'm a fat boy, and I don't deal well with heat. Now? Okay. All right. Hypothermia, same thing. Look at the pathophysiology of frostbite, which is, again, frostbite is a type of what type of injury that we've already talked about at the very beginning? Say it again loud. It can lead to necrosis as a result of what? As a result of what? So you're both right, but as a result of what? Again? It's a type of burn. Compartment syndrome. Is that what you're saying? Okay, compartment syndrome. Again, cells literally begin to freeze, and the fluid that surrounds the cells freezes first. And what does liquid do when it freezes? It expands. Now, we're reducing the circulation and we're compressing the cells, okay? So we can have hypoxia, we can have burns, and it leads into that situation. Big thing to remember is that you don't want to thaw a frostbite if there's any possibility of it refreezing, all right? With hypothermia, generalized hypothermia, the big thing we're really concerned about is irritability of the heart. Because if we bump our patient or we hit the railroad tracks too hard, we can put our patient into ventricular fibrillation. Hypothermic patients do not react well with, or do not react really positively to defibrillation. All right? Pardon? Because of the irritability of the heart. Generally, what will happen is that you will. Typically, what you call for is one defibrillation until you warm your patient up. And in that situation, still going to do chest compressions, good adequate CPR, but we're going to try to get our patient as warm as we can. The other thing to keep in mind, especially if your patient has been down very long with hypothermia, whether it's a cold water drowning or if they're out in cold weather, like you guys have. You have real winter where you're from, okay? We're going to extend the resuscitation time. So hypothermic patients are not dead until they are warm and dead, okay? Same situation as far as with a patient in a near drowning incident. Number one, don't worry about trying to get fluid out of the lungs or the stomach because there's only going to be very little bit there. The big thing that we're going to do is be concerned about potential spinal injury, get them out on a board, start CPR. Again, depending upon the temperature of the water, if they fall through a pond up at Bella's place, we're going to extend it out much longer than we would if they fell in a lake in Florida in July because of the temperature of the water. And so regular resuscitation for our patient. That, ladies and gentlemen, is your exam. Questions? Anything I can help you with?
Can we go through IVs, like what type of IVs should we have in this transition?
Yeah, so what we're looking at, your best use, now obviously you're going to use normal saline, okay? Normal saline is great for medical emergencies, all right? So it's fine because generally we're not looking at a whole lot of making acidosis worse. Got a patient in diabetic ketoacidosis, they're going to be acidotic, but again, it's kind of like going to the ocean and saying, whoa, I'm going to make the ocean saltier by putting a teaspoon of salt into the ocean. It makes no difference, okay, because they're already so acidotic. So medical emergencies, heat-related emergencies, it's really good as well because part of the problem with your heat-related emergencies is that you've lost sodium, okay? Now, we're also going to be really concerned with heat-related emergencies as far as chloride and potassium, but until it's really widespread of where you do labs, probably not going to worry about administering potassium pre-hospital-wide. For your lactated ringers, it's really, really good for your patients who have some type of trauma. And but now here's the other thing to remember is that if you've got a patient that has got serious trauma and you think that they're going to need blood, start one LR and one normal saline. Why? You can't give blood through anything but normal saline.
So are you just splitting the dose in half between the two?
Now, what do you mean by split the dose in half?
20 milliliters per pill, you just do 10 of pill
Nope, you do 20 of LR and get ready to change your bag. If you've got a good IV, and maybe that'll be something. Maybe we'll time that out in 360. I've never done that over the in the spring. We'll see how long it takes based upon the diameter and the length of your catheter to see how long it takes gravity just to let it fuse in. It'll be quick. So you'll just change this out. The primary reason that you're wanting your normal saline is going to be getting all of the red blood cells in, and then to follow that up with a flush afterwards. If you give it with lactated ringers, there's a possibility that you can cause hemolysis or a rupture of the red blood cells. Not a good thing. So good question. So that would be the thing. In D5, you're rarely, if ever, going to use it. Rarely. D5W. Good question. Anybody else? Everybody feel confident?
No.
You give us a simple study guide,
Uh-huh.
and then you come out with this bang exam. Yeah, so.
Whether you